Hi, my name is Thomas Scheeren. I'm working at the University Medical Center in Groningen in the Netherlands. And these are my disclosures. We are talking about predicting of hypertension today. Why would we like to predict hypertension? Because there's convincing evidence that hypertension, whatever the definition is common, is associated with poor outcomes. Most of all, myocardial injury, renal injury, stroke, and mortality. So the question is, can prediction of hypertension reduce its incidence and its consequences? What is the problem? So the monitoring that we do, real-time monitoring, is excellent at telling you if the patient is stable or not at this moment, but it's not very good as detecting the instability early. This is a quote from Michael Pinsky. And this is a paper imagining how the hemodynamic monitoring would look like in 30 years, in 2050. And we will have, they predict that we will have a data integration and fusion to end up in a predictive analysis for the prediction of adverse events such as hypertension. And I will show you today that we maybe have not to wait until 2050 to make this happen. This is all based on machine learning, big data, and artificial intelligence to come up with a predictive algorithm for an event. When we talk about hypertension, what is the problem? When the clinical signs of hypertension occur, this is the point where the compensatory mechanisms of the organism fail and the blood pressure drops. But the reason for the hypertension lies in the past, way before. And we could normally not see this, detect this. And it would be very nice to have a look at this point to detect the development of an hypertension early before it actually occurs. That is the idea behind this. And this mechanism is based on arterial waveform analysis. If we pick up one arterial pressure waveform, it contains many information, such as on contractility, the stroke volumes, the area under this curve. It tells you something about compliance, afterload, and vascular tone. All this information cannot be seen with your eye, but the machine learning can do this very nicely. And this has been performed in this paper where they developed the prediction hypertension index, and they made use of analysis of the arterial waveform. They divided it into different parts and came up with more than 3,000 features, which they then combined and came up with the prediction model. And this was tested in various patient cohorts from the ICU, from the OR, the MIMIC database, and also an external validation took place with patient data from a different site. And these were the results. So as you can see, this new hypertension prediction index performed very well at predicting hypertension 5, 10, or 15 minutes before the hypertension actually occurs. And this was much better than the development of changes in mean arterial pressure could predict hypertension. These are the results from the external validation. Well, and this is an example from that paper, an intraoperative case showing the development of mean arterial pressure. So the mean arterial pressure drops at this point a little bit, but way before the 65 threshold. At this point, the HPI gives an alarm, so more than 85% is an alarm raising, telling you that the prediction might occur. But then it took another 17 minutes until the blood pressure actually dropped below 65. And these 17 minutes could have been used to find the reason behind the hypertension and to treat it or prevent it from occurring. That is the idea. We did an external validation of this hypertension prediction index. How does it work in our setting? We looked at patients undergoing major surgery and receiving goal-directed fluid therapy. And as you can see, the higher the hypertension prediction index number was, the higher was the actual event rate that we observed, and the shorter was the median time until the hypotensive event. And we also did ROC analysis of the performance of this new index compared to the changes of mean arterial pressure. So here you see the hypertension prediction index 0 minutes, 5 minutes, 10 and 15 minutes before the occurrence of hypotension, which was pretty good. And if you compare this to the changes in mean arterial pressure, even at the occurrence of hypertension, so 0 minutes and 10, 15, 5, 10 and 15 minutes, it was not very good at predicting, or even not able to predict. This is just like flipping the coin. And if we compare this to other hemodynamic variables, which we did here, so for example, cardiac output, stroke volume variation, pulse pressure, shock index, and so forth, we can see that none of these variables could predict the occurrence of hypotension as good as the hypotension prediction index. And this can even be done non-invasively, and when the arterial pressure waveform is derived non-invasively, as you can see here, the same good performance with a non-invasively derived signal. So this will allow to widen the range of patients who might benefit, patients that don't even have an arterial line. And what is the idea behind this hypertension prediction index? So this is a traditional treatment of a patient. So we wait until the hypertension occurs because we cannot predict it. Then we treat it, and then the hypertension is resolved. With this new hypertension prediction index, we will have an early warning of this hypertension, and then at this point we can treat instead of at this point, and this way we might prevent the hypertension from occurring and might prevent also the complications. That this actually works has been shown from this study from Germany in patients undergoing hip surgery, and the incidence of hypotension was actually reduced from 88% to 48% by using this hypertension prediction index. So you cannot prevent all of the hypertensive events, but a big part of it. And when we look in more detail, you can see that the hypertensive events went from 5 events in the control group to 0 per hour in the HBI group, and the duration from 11 minutes in the control group to 0 minutes again in the HBI group. And this was 6% of the case time that the patient was hypertensive in the control group compared to 0 minutes after this hypertension prediction index has been introduced. And this is the HYPE study recently published in JAMA from the Netherlands, which did pretty much the same thing, but in patients undergoing major abdominal surgery. Again, they use this, they call this early warning system, which is the same, which is a hypertension prediction index. And if they compared this to patients receiving the standard monitoring, they could show that the mean time-weighted mean average of hypertension could be significantly reduced by using this hypertension prediction index. And this variable also gives you some idea what the reason behind the hypertension is, to allow you a causal treatment of the hypertension. Of course, you could treat any hypertension with a vasopressor, but maybe this is not the good treatment in every patient. And this secondary screen helps you deciding which is the optimal treatment. And it uses variables of preload. And if this is a problem, volume would be the adequate therapy. It also measures contractility. And if this is a problem, an inotrope might be the best treatment. And if it also looks at the afterload, and if this is a problem, then the vasopressor would be the right choice. How does it work? Of course, you know these dynamic variables based on heart-lung interaction, which can predict if a patient is hypotensive, is food responsive or not. We will not go into detail. The new thing is the estimation of contractility, which is based on the dPdT max, so the speed that the arterial pressure upstroke is performing. If a heart is contracting very well, this increase will be very steep, the number will be very high. If the heart is contracting poorly, this increase will be less. And this can also be derived from the peripheral artery. And the third thing is the dynamic arterial elastance, which is just the ratio of pulse pressure variation and stroke volume variation, and this is based on the pressure volume curve. It tells you which position your patient is on the individual pressure volume curve, and this may tell you if the blood pressure will rise if you give fluid to your patient. So it's a stroke volume variation of the pressure world, if you will. So taken together, intraoperative hypotension is common even in flow or volume optimized patients. It is associated with poor outcome, and it can be predicted in 2020. The Acumen Hypotension Prediction Index predicts hypotension reliably up to 15 minutes before its occurrence, and it predicts hypotension better than changes in mean arterial pressure or any other hemodynamic variables can do. So it buys you time to take measures before the event actually occurs, and it will probably change your practice from a reactive management, so waiting until the hypotension occurs and then treat it, to a proactive management, and from an unspecific treatment, so treating every hypertension with volume only or vasopressors only, to a more causative blood pressure measurements depending on the reason of the hypertension. But of course, we need further studies to show that if we do this, if we can prevent hypertension, that this has an impact on the outcome of our patients. Thank you very much.